Good evening, everyone. I'm Sarah Loudon from Total Health Conferencing, and welcome to a virtual town hall, Kidney Cancer in the Time of COVID. This is one in a series of town halls we've been doing with various tumor types. So we've done 2 in colorectal cancer, 1 for lung cancer, 1 for breast cancer, and tonight we have the honor of being joined by very important people who have really informative things to tell you about kidney cancer. So as always, I'll just introduce who's part of our panel tonight. We'll start with 3 advocacy organizations, the Kidney Cancer Association, KidneyCan, and the Powerful Patient. And then we'll be joined by 3 physicians who specialize in kidney cancers, Dr Bhupathi from US Oncology, Dr. Braun from Dana-Faber Cancer Institute, and Dr. Bratslavsky from Upstate Medical University. We will have an interview with an industry partner, Pfizer, and then we will round out the program with a patient testimonial and then finish with question and answers. So we know that, in our past programs, the question and answer sessions have been really powerful for the listening audience. Please feel free at any time during the session. If you are one of our registered attendees, please put your question in the Q&A. And if you're watching us on Facebook, please just put your question in the chat and we will do our best to answer it live. So I'd like to ask my team to cue the advocacy leadership so that we can get right away started getting to know more about them and their organizations and the resources that they provide to patients. Okay, so thank you all for joining us this evening. This has been such a great series for us at Total Health Conferencing. We've gotten to meet really important advocates, people who have really dedicated their lives either as a survivor themselves or being affected by cancer with someone in their family, or just being drawn, to have a passion for advocacy. So I'd like to ask each one of you, we're joined by Gretchen Vaughn, the CEO of Kidney Cancer Association, Brian Lewis, the president of KidneyCan, and Joyce Graff, the president of the Powerful Patient. I'd like for each one of you to tell me a little bit about your organization and since all 3 of you are at the head of the leadership, a little bit about how the organization came to be. Gretchen, I'd like to start with you for the Kidney Cancer Association.
Thank you, Sarah. The Kidney Cancer Association was actually founded in 1990 by a then kidney cancer patient, Eugene Schoenfeld, along with a small group of other patients and his doctors in the Chicago, Illinois area, and who pretty much they all had the same passion, felt like more could and should be done in the kidney cancer arena. Some of those same original founders actually still serve on our board today, which we are proud to say, and are wonderful reminders as to what Mr. Schoenfeld originally set out to accomplish, and we certainly have not lost sight of that. Fast forward to today, though the Kidney Cancer Association has grown into a far-reaching international nonprofit organization, our mission and vision of being dedicated to serving and empowering our patients, their caregivers, and the medical community with whom take care of them through advocacy, research, and education remain our mission and vision today as it was when Eugene started the organization in 1990.
When I've heard the stories of how these organizations kind of came to be, we had for our breast cancer program a young woman. She was diagnosed with triple-negative breast cancer in her 20s. And she talked about, I asked her how this Tigerlily Foundation was founded, and she said, it was in my hospital bed. I thought to myself, I don't want someone to have to go through the experience that I had, being a minority, kind of being overlooked, being told, because I'm young, I don't have high risk for something that I was feeling in my breast that was very disturbing to me. And so when I hear about people like Eugene, you know, people that just say, I'm doing this, I find that to be so inspiring. And certainly I think the passion that they brought to the establishment lives on through the way that all the people engaged in what you do really kind of perform and commit to doing their job. So I love hearing these stories because I think it's just so inspiring, especially at a time like this. Brian, can you talk to us a little bit about KidneyCan, your role, you know, how it was developed, et cetera?
Absolutely. Good evening, everyone. Thank you for joining us. I first off want to say thank you to the organizers and the supporters of putting this on, but I also want to take a moment. I'd be remiss if we didn't thank all of the healthcare workers that are out on the front line. We really appreciate the sacrifice that each of you is doing for not only your community, but for the nation. So thank you on behalf of all of the kidney cancer community. KidneyCan was formed about 3 years ago. It's germinated from two different organizations that blended. Ralph and Brendan Knapp down in Virginia, and I joined forces and created KidneyCan. We're a little bit of a twist on the patient advocacy organization in that we're focused on accelerating research to find a cure. And we find two vehicles that we can do that in. And one is private funding, where we're out trying to raise funds to fund preclinical and innovative types of research, as well as investigator-led research. But then more importantly, I've been spending a lot of time in the policy advocacy space in an attempt to get public funding, where we think we've been able to move the needle from several years ago where kidney cancer did not have, had zero federally directed funding in 2016. And now today we're proud to say that we have, through a combined effort of a lot of organizations, a lot of people, $40 million for kidney cancer research. So we're pretty excited about that.
That's something definitely to be excited about. And as we go forward, I'll probably dive a little deeper into some of your policy efforts. Joyce, thank you for being here with us. Can you share a little bit about the Powerful Patient and your role there?
Sure, I'm Joyce Graff, and in 1993, I set up the VHL Alliance, and I retired from that several years ago, but the Powerful Patient is an outgrowth of that experience. We're a small nonprofit consisting of just 3 longtime advocates for kidney cancer who come to it from different perspectives. Each one of us has more than 20 years experience with patient advocacy. We all started with kidney cancer and have learned that those skills transfer to a number of other conditions. Our goal is to empower people to manage their own health, to learn how to find the most authoritative information on the internet, to find the best doctors for their condition, how to manage the many doctors they need to interact with, and how to manage their own emotions through it all. So we coach people in all those realms, and we direct them to the expert resources and patient support hotlines that already exist for their conditions. My colleague Mike Long is a 20-year survivor with metastatic kidney cancer. So he's an inspiration to many of us, and he serves as a research advocate with 2 prominent research teams. He also leads patient support groups at several nearby hospitals in North Carolina and works with hospice patients in his area. My colleague Robin Martinez is the lead moderator for smartpatients.com. She was the caregiver for her husband through his own fight with kidney cancer and brought those skills to the wider arena of other diseases at smartpatients.com. She's in a key position to learn from those discussions. And in March, at Robin's suggestion, we interviewed Steve Taylor from the Sjogren Syndrome Foundation and alerted people to the potential shortages of hydroxychloroquine. My own background is in von Hippel-Lindau disease, VHL, beginning in 1963 with my husband's adventures with VHL. He had 14 rounds of major surgery in 15 years, which in itself is a big thing to manage. Hello?
Yep, we got you.
Oh, okay. He died from complications from kidney cancer. So VHL is the leading cause of familial kidney cancer. It is clear cell renal cell carcinoma with a twist. So at the cellular level, it's the same as 85% of all the kidney cancer in the general population. The NIH has been studying VHL for 30 years, and VHL research has led us to the many drug options that now exist for kidney cancer. But there are some distinct differences for patients with the familial form of kidney cancers. The average age of onset is 20 years younger than in the general population. And my son was diagnosed with VHL at the age of 14 with multiple kidney cancer tumors in both kidneys. At that time, in 1985, they told us that, quote, the only cure for kidney cancer is to remove both kidneys, unquote. Well, to us, it didn't sound like much of a cure. So with other VHL families, I've formed an organization, and together with a number of wonderful doctors around the world, we developed strategies for managing our health. And today, the prospect for people with kidney cancer is dimensions better than it used to be. In the 1980s, it was one of the leading causes of death for people with VHL. And now today, it's pretty manageable for most folks with VHL. But there's good news and bad news in that. The good news is that if you know you're at risk, we can usually find those tumors early when it's more likely to be successfully treated. The bad news is this is probably not your last kidney cancer tumor. So it's essential that we and all our doctors take actions that will preserve our kidney function throughout our lives. So while we rely on experts for advice, our experience tells us that the patients also have to take responsibility for their own health care. Patients have to listen, to show up for scans, to work as members of the team with their doctors and participate in their own care.
Mm-hmm. You know, you said a lot there, Joyce, but I think that the people that are listening can all identify with various areas that you talked about. And as I go forward, both in this segment for the advocacy leadership, as well as in the medical experts, I really do want to touch on, you know, each one of us as a patient we are our greatest advocate. And really equipping and empowering people with information and education, and just the understanding that we are part of the treatment team. We are part of the decision making that goes on when people are treating us and our disease is just as important as you know, the treatment team themselves making decisions. So I really love that so much of what the Powerful Patient, and what a great name, advocates for is empowerment. So we'll get more into that. Gretchen, you know, COVID-19 kind of came out of nowhere and changed the way we all do everything. And I feel like advocacy organizations, you know, educational organizations like ours, even the way, you know, institutions, both community and academic, how we reach our audience had to rapidly change in order to kind of, you know, replace what we were used to doing conventionally. Can you share any of the ways that you responded as an organization, and maybe what the results of those response or those decisions may have been?
Sure. I mean, you know, we're fortunate, if that's even such a thing during a time of COVID, to be so advanced technologically. Being a global organization, we were already pretty remote in a lot of the ways we communicated with our audiences. So the first thing we did was really kind of revamp our website so that it would be a primary place, an easy place to find critical information that's literally changing minute to minute. I think the hardest thing for anyone, whether it's you were just diagnosed with cancer or you're looking for up-to-date COVID information or whatnot, is just to know what's a reliable source.
Yeah.
So we really tried to look to Twitter, as well as our medical steering committee and all of the physicians within our medical community, to keep up-to-date and live information as much as we can on our website in one place. And we have gone back and updated. We have an Ask the Experts area, a resource page, And we have even gone in there and changed answers on a weekly basis, just with more information that's coming out. So we've been trying to do stories on it and focused articles and events and social media and things of that nature. But really, the main goal is to just stay on top of the information and make sure and ensure that the patients, the caregivers, have accurate information, because there's so much bad information out there.
Yeah, we had a lung cancer doctor, Casmi, from Cancer Treatment Centers, and she was saying, while we have this pandemic, this kind of health crisis pandemic, we also have a pandemic of misinformation.
Yes.
And I think that really was such a great way to put it, because it's uncontrollable. You know, it's everywhere and it's uncontrollable. So I appreciate so much when, you know, organizations like the Kidney Cancer Association becomes that like credible, reliable source. Gretchen, what's the website for Kidney Cancer Association?
It's kidneycancer.org.
Kidneycancer.org. Wonderful. Brian, you talked about policy, you know, lobbying, research, fundraising, private-public partnerships, and, you know, developing research programs around kidney cancer. I can't imagine that shifting to doing this virtually has been easy. So, you know, that I think of you and I think, boy, you really have to have, you know, chops to move forward in this new Zoom environment where, you know, you don't get the benefit of looking eyeball to eyeball in person to someone. You know, how has that affected policy and lobbying and fundraising?
Well, thanks, Sarah, for the question. I think to start off with just a little bit of history, in March 9th and 10th, we had a Capitol Hill Days in Washington, D.C., where we had 30 advocates come up on the Hill, and we had 92 appointments with 12 elected representatives and senators. You know, incrementally, we're growing those meetings every time. And as we were going into Monday, we got a few calls that converted some of those meetings to teleconferences. It was right at the beginning of the COVID-19 pandemic hitting the United States hard. And on the 13th of March, the Capitol closed down. Yeah. And from that point forward, things have been changing in terms of how do you navigate the landscape of Washington, D.C. As we all know, it's shut down. And they're not allowing anybody except for sort of essential staff and related witnesses that are coming in to testify and other things to get into the building. So we've had to pivot like most organizations. And we've come up with a couple of ideas, and actually Gretchen and the KCA and the National Kidney Foundation and others are partnering with us. We've created what we're calling district days. And we've decided this August 12th and 13th to turn around and ask the constituents across the country that are in the kidney cancer community to take a day and go and visit with their local representatives. Now, it's a little bit of a bold step on our part because of the social distancing requirements, and we of course are taking into account any patient or patient that has any kind of immunocompromised situation or any pre-existing condition that could be compromised in those kind of environments. So, but we're moving forward. We've gotten some good response from the community. We've already have, I think, 15 or 16 people signed up, and we're trying to grow it to 50. And we feel pretty confident that we can do that. We're gonna then have Senate phone calls on the 13th, because we don't know the states, where people are geographically. There are only so many Senate offices in a state, so we didn't wanna make people travel. So we're going to try this out. We've got the partnership with these other organizations. We're all going to be reaching across the community to try to do, to have some effect while this is going on. And I think one of the things I'd like the folks on this call to listen to is constituents count out there. Your vote counts. And I don't want you to hesitate for a moment to think that just your one little voice can't make a difference. It does. And so I'm imploring folks, come out with us, come out as a community, and let's have our voice heard in August.
Yeah, I really, I echo that. What you're saying here in other tumor types as well. There was the colorectal cancer community, they typically have March as their awareness month. And, they were talking about, it felt like March was stolen from them. And it really was so emotional for them because they didn't feel like, you know, all the social activities and the runs and the fights and the rock climbing and all those different things that they do was stolen. They really felt like people that have the ability to change things were not given the ability to listen to those individual voices of how much it mattered. And so, you know, they're working to kind of take back March at some point. And I love that what you're doing is saying, you know, we're not going to compromise on the fact that we need to have our voices heard, and developing these district days and these Senate phone calls. Look, where there's a will, there's a way. And each person that's affected by cancer, either personally or with a loved one, you know, it does, everybody's voice does matter and does count. And it's one by one that we make change.
If I could just comment on that, I think, you know, something to also remember is that, you know, just because we have this pandemic, not just because, but in light of the pandemic, people are still being diagnosed every day with cancer. And so we can't stop what we're doing and what others are doing on behalf of the patient community. There's a lot of anxiety out there. There's a lot of fear of the unknown. There's been some delays and postponements across the country in care. And, you know, we just need to keep speaking loudly and have our voice consistent and unified and let those decision makers know that we as a community are standing behind what's going on and trying to, you know, help with what we can do, but we also need to have the patient taken into account as we move through this pandemic.
Yes, absolutely. And I thank you all for, you know, collaborating too in this time, because it really, again, shows the power of each one of your missions individually and then collectively. Joyce, you know, as I was doing my research on each one of your groups, and I got to Google the Powerful Patient and just kind of take a look at what you stand for. You know, you talk about managing, helping to empower the patient to manage the system, to manage their health, and to manage their life.
Right.
And I don't know that there's a more appropriate time in really our lifetimes that all of us collectively have to learn how to manage our systems, our health, and our lives. So, you know, tell me how you as an organization determined or decided that those were three crucial areas that you needed to be able to empower your patients.
Yeah, I think it's the lessons that we've learned as patients and as caregivers, our own selves, and realizing that it really starts in your own self and in your own heart. And that's why I'm so glad that we have as many organizations as we do with different charters. I applaud everything that the other two panelists are doing. I think it's wonderful. The little bit that we try to add to that equation, in some cases, in this time of Corona, you could say that we've almost pulled back. We're doing more regional work than national work at this time. I've done more one-on-one advocacy this year than I have for a long time, both in kidney cancer, in transplantation, with various other conditions, but also with the sort of side effects of cabin fever, elder abuse, domestic abuse, mental health, dementia. As we shelter from coronavirus, in some ways the world has gotten smaller and our focus has come inward. And at the same time, the opportunities for the global interactions, as Gretchen described, have gotten much easier. And Robin Martinez's work in particular with smartpatients.com has global impact. But in addition to our podcast, we've been experimenting with video, and we've been working with our local cable TV station so that some of our broadcasts now are in video and on YouTube and on Facebook and also on Channel 3 of Brookline's cable TV network. But we're also sensitive to the fact that older people and poorer people don't have access to these technologies. And so they still need to be served on the telephone, audio only. So we're still continuing to do podcasts and telephone support one-on-one.
Mm-hmm. I'm so amazed. You know, we think about what we've had to do, especially in the early weeks of this, especially balancing too, that this was happening to us individually as well as, you know, the businesses or organizations that we represented. I'm so impressed by the way everyone has kind of innovated. And I do hope that so much of what we've learned through COVID, you know, how to connect to people, how to access people, how to be flexible, embrace change. I hope a lot of that stays. The things I miss, of course, are the one-on-ones, the hugs, you know, the feelings of connection that you don't really get when you're working through a screen. Gretchen, Joyce talked about poorer patients or older patients, and you know, we've always struggled with how to get these groups of people to be compliant with treatment, to be compliant with visits, to have a wealth of information about their disease. How does your organization serve these populations? And maybe you can kind of tell us, you know, as the lay people listening, if we know people that are affected with kidney cancer, how do we share those resources with them?
Sure. So I think one of the things that we've been working on really in this last entire year prior to the pandemic, which really fortuitously has come together at this time, was just taking a step back and refocusing on the patient and the caregiver and how can we better serve them. It's not that we didn't always have these resources for them. It was just, were they the right resources? So we really have invested a lot of time this last year in reaching out to the communities of patients and caregivers and whatnot, and really anybody that's been touched by kidney cancer in general, and ask the question to see where do we need to pivot and where do we need to do a better job. And ironically, you know, so many older people do not have access to a computer or don't want to, quite frankly, my mother included, and I don't consider her old. But with that being said, we have hired, and actually they start June 1st, so in a couple of weeks, but we have hired a frontline patient liaison whom we hope will be the, you know, first main line in contact with an actual human being to do nothing but hold their hand through from the time that they are diagnosed all the way through their end of care and they're ringing the bell. We find that, like we had talked about earlier, the idea of, you know, so much information being out there, not knowing which sources or are reputable, what to do next. We want to take as much of that kind of that fear factor away from them, but at the same time empower them to take charge of this process from start to finish and hold their hands throughout the entire thing. So it will be more of a relationship based instead of just a technological, here's a website, here's some information. With that being said, it's almost simultaneously going to roll out a Just Diagnosed toolkit. It will be online, but it will also be able to be printable, downloadable, and in hard copy. And at some point, we would like to put this in doctors' offices as well. That will literally walk them. There'll be a roadmap as to what to do first, how to go about it, what, you know, resources in your own community, in your own area, and then where to go if you still have questions, which would be always to come back to a live person, our patient liaison person.
Yeah. And just as a follow-up, just because I'm curious, how do you determine where and how to dispatch that kind of individual one-on-one patient liaison group that you have?
I wouldn't say it's a group. We've hired one person so far, but with a team of people supporting their efforts behind the scenes. You know, we already have a following and a patient population that have kind of been with the KCA for many years. We also have a support group through Inspire. And so, you know, I think that the kidney cancer space is still small enough where it's intimate and people, their resources are somewhat still limited as opposed to like breast cancer or prostate cancer. But they know where to go and where to come. We just need to do a better job of getting the information out there and disseminating it whether it be through their local doctors, online, social media, and hopefully one day, face-to-face, in-person, patient educational meetings and symposiums in their local community in conjunction with their local hospitals as well.
Yeah. Brian, we're living in times where connection, no matter what connection looks like, is so vital. And I noted from one of your previous answers that, you work alongside other advocacy organizations to create things like these district days, Senate phone call days, and just kind of organize, rally the membership of various organizations. Do you find that during COVID-19, it's easier to reach out and create those collaborations? Or do you think just by the nature of all of you ultimately serving the patient, that's, relatively the way it is status quo?
That's a great question. I think a quick answer would be, since Gretchen's leadership has started at the KCA, there's been a revival in the kidney cancer community, and there is a momentum around joining forces where we can, and participating, speaking as one voice in Washington, D.C. is the area that I focus on. And I think in this time, I think there is a camaraderie or a willingness to try to figure out how we can amplify our voice or work together more closely. So absolutely, yes.
And then, as a follow-up for you, you're trying to kind of tie together a lot of ships with a lot of different destinations in terms of their mission, their vision, their organizational structure, et cetera. How do you keep, all of that organized in your role, where you're not just balancing, the daily operations of KidneyCan, but you're also trying to develop this stronger, more amplified voice? What are kind of the tips and tricks that you employ?
Wow, you want to look behind the wizards?
Yes.
Thank you for that question. I think a quick answer here would be, I'm surrounded by a team of dedicated, thoughtful, hardworking volunteers and staff that are willing to go the extra mile for the community. And it wouldn't be possible without, folks at Smart Patients, without Susan Poteet, without Angie, without the folks out on Smart Patients. I got a shout out to Sean T today, who's going to keep fighting, and Ayla and Z15 and Cindy 90. I mean, there's a lot of folks out there that are really committed to this, predicament that we're in, not only being diagnosed with kidney cancer, but looking for a cure, finding a cure, and also doing political and policy advocacy. So we've got a good community out there. We're all tied together.
And Brian, one last thing, not one last thing, but in this train of thought, tell me the website for KidneyCan.
You got it, kidneycan.org.
Wonderful. Joyce, I love to see the spread of representation that we have, with large organizations, with organizations that are very focused in their charter, and then with organizations like yours that are just so personal. I really was moved when you said you've done more one-on-ones for advocacy these days than you have in a very long time. It really, I think that it kind of honors your purpose in this, your husband's legacy, and your drive to kind of move things forward. How are you taking care of yourself at this time where, we can do so much that it causes fatigue? How are you taking care of yourself?
Well, and it's not just me. I mean, my son is here in the building. I have a 3-family house, and he lives on the 3rd floor and I live on the 1st floor. And so we have a little community here, and my son is 50 years old. He has a kidney transplant that's 20 years old, and he has some serious deficits from the long-term issues with von Hippel-Lindau disease that he has had to deal with. So one of the things we've wrestled with is not only taking care of the caregiver, but also this very fine line between how much do I need to panic and how much do I need to hold on? You know, we've almost been to the hospital twice. We have been to the hospital once, and it's not about corona. It's about the underlying medical conditions. And I think what I want to say to patients is you need to be cautious about going to the hospital, but work with your team. Don't be afraid to go to the hospital, and don't, whatever you do, don't withhold symptoms, particularly if you're on treatment for kidney cancer. Staying in touch with your team, telling them what you're going through is extraordinarily important, particularly in a time like this. Don't hold back those symptoms. Share them with your team and work with your team to decide if it's time to panic, if it's time to go to the hospital, whatever. Because there is a time and a place when your underlying condition is at least as dangerous as corona.
Mm-hmm. And Joyce, you know, that's the mark of an advocate. I asked you a question about how you're taking care of yourself, and you gave me an answer on how people can take care of themselves.
Yeah.
So it truly speaks volumes of who you are, and that you really were cut out and called for this. Joyce, tell me how people can get more information about A Powerful Patient. What's your website info?
It's powerfulpatient.org.
Wonderful. So, I mean, we've got about 5 minutes left. If each one of you could give me, you know, a minute takeaway, if you could only tell your membership one thing in this moment, in this COVID-19 situation, with them either as a patient or a caregiver of a patient with kidney cancer. Gretchen, we'll start with you. What's the one thing you want people to take away from this segment?
I think the main thing right now is for everyone to know that they are not forgotten. We are still standing strong and focused on our mission and vision. We are not slowing down in the work that we are doing to support them. If anything, we're going faster. We're adding more resources at a time where people really need to feel connected because they're feeling so isolated, I think, right now. We just want to help them do the right thing, get the best care, which is even harder than it was before, obviously, during this pandemic, and to know what that is and what that looks like Joyce was talking about, when to go to the hospital, when not to go to the hospital. So anything we can do to stay the course, they are not alone. I think that's the main message.
Mm-hmm. I love that. Brian, how about you?
Uncertainty in this time creates anxiety, and all patients and their caregivers and families need to join together to help the patient manage and walk through this time together. We've heard sad stories of folks that are only allowed to go by themselves to seek medical care or be entered into a clinic, and that's just wrong to me. We're better than that as a country. I know that there's certain risks in this situation, but the patients out there should be allowed to have loved ones with them in these difficult times. And I think we should work on that as a community. And I think, you know, the patients that are listening in should understand that engaging and activating in this community will help us all, and it will help us find a cure, and not just sit there by yourselves, but engage. And we need you, and we need you to help us speak as one voice. Thank you.
Mm-hmm. Thank you, Brian. Joyce, how about you?
I think I want everybody to realize that you are the most important person on your healthcare team. You are with your body and your mind 24 hours a day. You need to listen to your body and trust your instincts and calm your mind. Find something that brings you joy. One of the things my son is doing is taking harmonica lessons over the internet.
I love it.
So, you know, find something that gives you joy, and make sure that you stay in touch with the people around you, either touch them or virtually be in touch. I've been in touch with cousins who live in Paris and in different places like that. So the technology can bring us together too. Yeah. But keep track of your symptoms, watch patterns, share them with doctors, report all your symptoms and make sure that you stay in touch with your healthcare team and lead that team. For us, it's been negotiating with the team. They said, we want you in the hospital. My son said, well, not really. Can I do this at home? And we negotiated a plan that allowed him to do it at home. So take some control and work carefully with your team. You are the most important member of that team.
I love that. Thank you. Thank you, Joyce. And thank you, Brian and Gretchen too. Don't go anywhere. You know, there's some questions in the Q&A. We'll be back for Q&A at the end. Thank you, all three of you, for spending your time with us today. It's so important. You know, I want to echo what all three of you have said in one way or another. Being connected is so important in the cancer community. And so many times we kind of think about that as top down, you know, what the doctors say or what the thought leaders say or what the pharmaceutical companies say about the disease is kind of the biggest voice, but it's not. It's like that N of one, that individual voice of a patient that's living through the experience sometimes is the most powerful way to communicate the impact of changes. So I just want to thank you on behalf of the kidney cancer community, and certainly on behalf of the medical education community, for being here and for giving your time. And I hope that, you know, as we all get together at the end of this town hall, that we're able to kind of get a little bit deeper with each one of your organizations. So I'm going to ask my team to bring up the medical experts next. And while they're doing it, again, I want to remind everybody that if you have any questions, either for the advocacy organizations or as the doctors join us, please feel free to add those to the chat or add those to the Facebook live page, and we will be sure that we start to bring that all back around. Okay, so hello, gentlemen. I'm grateful that we have each one of you joining us. I would like to ask for you each to introduce yourself, tell us a little bit about where you are in the world and where you practice. I'm going to start with you, Dr. Bhupathi.
Hello, thank you, Sarah, for having me today on this town hall. It's an interesting opportunity, and it's great that we're able to do that. You're able to do this for all the patients, actually. So I think it's great. So I am, my name is Dr Bhupathi. I'm a medical oncologist in Denver, Colorado. I primarily focus in breast and GU medical oncology. Yeah, that's a little bit about me.
Very good, very good. Dr. Braun?
Yeah, again, thank you so much for putting this on, and especially to all the patients and advocates that are participating. It's really nice. You know, I think it feels like a pretty isolating time, and so having events that's able to bring together the community, even if it's not in person, at least face-to-face, is incredibly nice. A little bit about myself. So I'm a physician scientist that focuses pretty much exclusively on kidney cancer. So I see patients with kidney cancer as a medical oncologist in the clinic at Dana-Faber here in Boston. And then I spend a substantial amount of my time doing laboratory-based research as well, trying to understand the genetics of kidney cancer, the genomic features, and the immune features of kidney cancer that lead some patients to get tremendous benefit from the drugs we have, and for other reasons why drugs fail to help other patients. And by trying to investigate this, we hope to learn what's the next step in terms of improving these types of therapies.
Yes, thank you, Doc. I'll be definitely diving more into the genetics and genomics of things as we go forward, because we do have a lot of questions about types of treatments during COVID-19. Does it matter, et cetera? So I can't wait to kind of dig a little deeper with you on that. And Dr. Bratslavsky, would you introduce yourself, please, where you're from?
Sure, Sarah, thanks for putting this together. I'm Gennady Bratslavsky. I presently practice in State University of New York, at Syracuse, at Upstate Medical University. Originally, I should say my training and focus in urologic oncology comes from the National Cancer Institutes and National Institutes of Health, where I have completed my fellowship training after I trained in urologic surgery here in the United States, in New York, Albany, New York. I have had a tremendous interest in management of patients with hereditary and genetic kidney syndromes, where I happen to know most of the advocates from every group and have been able to establish long-term relationship with many of them. I presently serve as I wear several hats. I'm a department chair in the Department of Urology. I also am a deputy director of the Cancer Center here at SUNY Upstate. And I'm also a surgeon scientist, as a portion of my time is spent with mentoring my PhD student, my medical students or residents. And I also study and look for several targets or specific ways of killing kidney cancer. We have a very large kidney cancer program in our institution, and we have several labs that cover span of genetics, biochemistry, immunology, as well as informatics and artificial intelligence. So we're trying to all come together. I brought in several people from NCI here. So those at NCI mistakenly call us NCI North, but I assure you it's true North. We just had snow on Mother's Day here. Wow. So for those stoic people who can survive here is not that bad. But overall, again, thank you for doing this. We're just like any part of the country. We're experiencing this, numerous changes and numerous accommodations and patient management. And for those of us in focus with kidney cancer, it certainly has been very different. It has helped us define what the next steps are often in treatment. It has made us postpone treatment in some cases, rush treatment, and even, quite frankly, even change some of the surgical planning and treatment in other cases. So it's been quite challenging, and I think our rapport with patients come a long way at this point.
Well, thank you so much. And Doc, I'll probably talk with you about the New York COVID-19 experience. So, as I was just kind of writing my notes on each one of you, we've got, Denver, Colorado, we've got Boston, Massachusetts, and then we've got upstate New York, very different experiences from COVID-19, very different ways that the academic and community medical practices have prepared and responded. When we started this town hall probably about, I don't know, 3-4 weeks ago, although time just blends into each other during this time for me, but 3 or 4 weeks ago, I was asking questions like, what are we going to do? And, Dr. Bhupathi, I'm gonna pivot to you and say, now that we're thinking about ways we reopen, how is your practice taking those changes? Apart from the typical social distancing, et cetera, how are you preparing patients to be able to come back to some type of normalcy in clinic scheduling?
Yeah, Sarah, that's a great question. It's also not an easy one to answer. I think, this pandemic has really, transformed a lot of things for all of our patients. The fact that we went from the face-to-face, person-to-person interaction to a virtual meeting to understand what the toxicities are for what a patient's going through, to now to figure out how are we going to go back to what we were doing to some extent has definitely been a big challenge. I think certainly there's been a lot of changes that we've made, and I think certain things are going to be coming to stay. The biggest thing is going to be telemedicine. We used to have most everybody come into clinic, and telemedicine was not something that was in the forefront, nor did we use it as much. It was starting to emerge in the background, but never to the extent that everybody had to get used to quite rapidly as we did. I mean, essentially, we got used to telemedicine in a period of 24 hours and saying, go. So it's definitely something that I think is going to be staying. Now, the question of, how are we going to replicate some of the human interaction using telemedicine is going to be the most challenging part, right? It's always difficult to assess how someone is truly truly experiencing toxicity or even adverse effects from the cancer itself while you're seeing them virtually, let alone privacy or anything else. So I think when you're trying to reopen and figure out what are you going to do next, some of these things are going to be important. How do we get back to the physical interaction? How do we get back to the support systems that we had, whether it be like a supportive group with other people, or even significant others, family members, even when my patients have fantastic news, they often just say, "Can I just give you a hug?" Like that even that most basic interaction is missing right now. So it's I think certainly those are probably going to be the biggest things that we're going to have to try to figure out how to reincorporate.
No, so much of what you said, I think, has kind of resonated throughout all of these town halls, both from the advocacy perspective and from the medical perspective. Dr. Braun, Dr. Bhupathi talked about how quickly we adapted, how quickly we kind of innovated, and then how quickly we adapted. So when you think about areas like telemedicine, it was, we could have dragged our feet for the next 20 years on incorporating it into clinical practice, but this kind of forced our hand. But you mentioned that a lot of your interest is in clinical sciences and in research. The same way we've made such significant advances to clinic visits, I believe, and maybe you can share your thoughts, we've taken some major steps back when it comes to, enrollment to clinical trials, et cetera. Do you have hope that we can innovate and adapt in the same way? Talk to me maybe about, your feelings on where we are with research.
Yeah, absolutely. And I think there's sort of two aspects. There's sort of the more laboratory-based research, whether that's actually physically in a lab or working with big data, which is a lot of the sort of genomic efforts now. And then, as you mentioned, there's clinical trial efforts as well. And the idea that, unfortunately, but very reasonably, enrollment has been down during the midst of the pandemic. And so I think there's a couple of things that can be helpful in terms of innovation. I'll start maybe with the latter, which is the clinical trial aspect. So one of those things is, it's been the rule so far that patients have to come in for every visit. They have to come in for toxicity checks. And I think there's real reasons for that, and there's often good reasons for that. But I think what telemedicine is beginning to teach us is there are situations where a lot can be accomplished remotely. And I think within Boston, a lot of academic centers, patients travel a great distance to come here. It's not a trivial thing. It's patients sometimes come for hours. And so the notion that for some of these visits, even if it's just a few here or there, we're able to really move those to telemedicine and really not lose much. I think that's a feature I really hope that we hold on to as we think about clinical trials. I think, clinical trials, it's how we move the field forward. They're absolutely critical, but they ask a lot of patients. There's a huge amount of burden put on patients to come in for so many study visits. And so if we can, learn from this experience to see what we can rebalance and be a little bit more flexible on things like study visits and doing telemedicine, I think that ultimately will be a small but important positive thing to come out of this. On the, oh, go ahead.
Go ahead. No, go.
I was going to say on the lab-based side, it's a bit tougher. I think, there are people who do a lot of big data kind of science, working with genomic information, and that's at least in part able to continue because we have such large data sets that we're able to, even working from home, it's not the same, but we're able to still get something done and make progress in trying to figure out what might be markers of response or resistance and trying to dive into the biology. But there's a lot that has to happen at the lab bench too, and at least so far, that's all been on hold. I think moving forward, we're learning a lot from things like what we've experienced in the clinic. How can we be operational, but in a safe way, and practicing physical distancing and all of these sorts of things. And I think every institution is trying to figure it out. I think this is going to be, flexibility is going to have to be the name of the game as we learn and iterate and continuously improve. But, you know, in the lab, moving to shifts, moving to situations where you can really keep people separate, I think that's going to allow things to really reopen, hopefully on the sooner side, so we can really get that research engine moving again.
Yes, it's so important. I mean, cancer treatment is as much about discovery than it is about treatment. Doc, is your clinic, I mean, is your lab open at Farber? Are you open, or?
So they've got, for now, in the midst of the pandemic, they've closed all labs except for just emergency personnel.
Yeah.
And so, you know, that doesn't mean we've stopped. We've shifted the focus now on, we've collected large data sets, huge sequencing efforts to understand what are the immune cells within kidney cancer, what are the genomics of kidney cancer. And so we're sort of working full throttle on that, and then planning when we do get back to the lab, whether the key experiments that we need to do to sort of go along with that hypothesis discovery work that we're doing right now.
Well, perhaps there'll be some small miracles that come out of being able to kind of sit down and crunch some data, which always seems to be the most tedious work when it comes to lab work.
No, I think you're right.
Dr. Bratslavsky, you know, New York and really the Northeast, including Boston, have been hit the hardest in the United States with COVID-19. How did practice change for you, and how did you communicate, and how do you communicate with patients to assure them that even through this pandemic, that their treatment won't be compromised?
Excellent question, Sarah. So I must, for the full disclosure, you know, Central New York is certainly nothing compared to, you know, downstate. And while we certainly had our deaths and our hospitalizations, our hospitals were never overwhelmed, just like they were in New York City. We were demanded by a governor to keep hospitals at 30 or 50% capacity at all times. And that, while that certainly has helped us be prepared for a you know, big spike, at the same time, it has certainly put a lot of additional burden, as we truly had to close our operating rooms except for emergency cases. And practice certainly has changed, just like anywhere. In 24 hours, just like Manoj said, we went to a telemedicine. And it's interesting how we rapidly were able to adapt. And part of your question is, how do we ensure a good continuity and lack of compromised care for these patients? Patients, in many cases, had been given options of going and getting scans done that are scheduled, or just postponing the scans. And I can't tell you how many just said, "Doc, how about we give it a couple of month break to get another set of scans?" Because there were some young patients that came to me where normally I would have had no hesitation to offer, for example, a surgery where I would be doing a kidney sparing approach. I would tell them that the only risk for you, if you were to have a kidney sparing approach, meaning where the tumor is removed and the rest of the kidney is left alone, I said the only risk is that you could have a small chance of bleeding and potential needing to come back to a hospital where you would need a blood transfusion. Something that I used to say so freely and so mindfulnessly. And patients that say, yeah, no problem, just do it. You know, just a thought that they may have to come to a hospital for any evaluation or any potential complication had made at least a couple say, you're taking that kidney out. Of course, some have appropriately elected to wait, and in many cases, obviously, we could. But there are some in some circumstances where, when you have a sister who died from a kidney cancer, from hereditary disease, you have a father who died from kidney cancer. In those cases, you couldn't explain to people that it's okay to maybe wait a little bit just because the chance of COVID is so high. So it has shifted our way of practicing in so many ways. We were able to still see and provide, I would say, outstanding cancer care. At the same time, our practice patterns, I do think, may have somewhat be affected, but this always involved a full disclosure. And it's interesting how in some of my conversations, I would often say, well, here's what we used to do, and these are what guidelines tell us to do in pre-COVID times.
Mm-hmm.
However, in COVID times, we are dealing now with A, B, C, D, E, and if we continue to do what we did, then you're just looking at some additional risk, and then you list them. And it's interesting how the surgical consents have changed, how the therapeutic consents have changed, how, as David mentioned, participation in clinical trials has changed, and sometimes it just all comes down to, will I need another visit to your office, to a hospital? And no matter how hard sometimes you try to state that, well, it's just one more visit for just a one quick assessment, sometimes that literally pushes a patient away from entering a clinical trial. Unless, of course, in many cases, we're able to agree with the sponsor or with the organization that is sponsoring the trial, either organization or a company that provides a treatment for the patients, to agree. So the visit is done using the telemedicine.
Mm-hmm.
But we were one of the first departments, if not the first one, to go hardcore telemedicine. We literally have spent a weekend early March in stating that we need to close down clinics, especially in urologic care, just like guys do in medical oncology. Even our general urologic patients are older men, often older men, and those are exactly the people you do not wish to be exposed to the emergency room. So one final thing I'll share with you is that we have extended our hours. And it's interesting how although I work in a state-affiliated facility, most of the nurses, certainly our state employees, everybody came together and they said, what can we do to keep patients out? And we literally went from a kind of a typical 8 to 5 office hours to 7 to 7 every single day, including weekends. Saturdays and Sundays, we have people in the clinic. We have done procedures in the clinic that we did not do before. We have been ready. We have given fluids, antibiotics, kept patients away from the hospital. Again, just every time feeling that we may be saving somebody's life because of the older, more vulnerable patient population. So there have been numerous changes that have occurred just as a result of this pandemic.
Yes, it's really incredible to think how, such a protocol or pathway-driven discipline like oncology has adapted to all of the restrictions that this pandemic has brought forward, and in a way that really does preserve the quality of care that patients have come to trust from their doctors. Manoj, we had actually David's colleague, Hal Burstein from the breast division. We had him on for a previous town hall, and he said something that applied to breast. And since you, in your introduction, you said, you focused on both breast and kidney cancers, I have this question for you. Forgive me if it doesn't apply, but, I think that it might really help patients. So he kind of encouraged us all when I asked the question of how do you maintain, treatments the way you did before COVID. He had this description where he said, if you considered chemotherapy, radiation therapy, and surgery almost 3 courses of a meal, appetizer, dinner, and dessert, it wouldn't necessarily matter if you had dessert first, followed by the appetizer, followed by dinner. Is it the same in kidney cancer? And have you had to make those decisions communicating to patients thinking that maybe down the line, as Dr. B talked about, maybe down the line, surgery would be something that we wouldn't have those restrictions on. Is it the same in kidney cancer? And did you have those conversations?
So yeah, Sarah, I certainly do have those conversations, and I think it's actually a very appropriate statement, and it's a great way of looking at it. You know, in this kind of pandemic setting, I think there's a couple more variables that we've never really been used to determining. So we always used to kind of just look at a patient's treatment and say, well, what is the real benefit you're going to get with this kind of treatment in terms of longevity, in terms of, you know, side effects and things like that. But here, now we're not only looking at what is the effect of the anti-cancer therapy, but then we also have to kind of calculate what is the likelihood that you may become infected with COVID-19? What is the likelihood that you'll be able to complete your course of treatment? And yeah, I have most certainly had patients where I had to modify modify how I would approach the treatment plan. You know, for patients that usually present with like early stage kidney cancer, you would normally take them to surgery. I've had young patients where we were not able to do that just because the hospitals are shut down. You know, when you look at advanced kidney cancer, surgery has kind of been moved away more so now. You know, you certainly, there's a role for surgery in advanced kidney cancer. But in very advanced kidney cancer, we tend to do systemic therapy first, whether it be oral drug agents or a combination of oral drug agent plus immunotherapy or immunotherapy and immunotherapy. For these young patients who are not able to undergo surgery and have localized disease, I have talked to them about doing systemic therapy up front. Now, there's not strong evidence for it, but certainly there is some evidence. And so we've kind of modified how we approach it. And our goal is to prevent further spread of cancer. So you essentially have your diagnosis, and then you go forward with your systemic therapy. And then you once you know that they're tolerating it well and things are starting to open up and their risk goes down, go for surgery at that point, and then come off of the systemic therapy unless they really need it for whatever reason. But calculating this risk and understanding which treatment to go with first has really been a big challenge. And, you know, and certainly in breast, we've been doing the same thing where we've started with anti-hormonal therapy, even for somebody that has curative cancer, because we couldn't get them to a surgery up front.
Mm-hmm, mm-hmm. I mean, it's challenging times. You all are responding in such incredible ways. I think about the future when we look back and we say, you know, there was something there, or you saw treatment responses differently there, and really have the benefit of almost this unrestricted research environment, because by way of, you know, just the restrictions we have, you have the ability to kind of change things around because you don't have a choice. So I often think, you know, what will we learn from the way we made different decisions during this time? Go ahead.
Sorry, I just wanted to add on. So when you talk about clinical trials, so I certainly do a lot of clinical trials, especially in GU. And we have a lot of novel clinical trials through US Oncology and through Sarah Cannon, which is almost a part of. And, you know, we've become quite innovative in terms of trying to maneuver the treatment trials. And, you know, we've had blood draws done at patients' homes for PKs sometimes. We've also had toxicity assessments that were done by telemedicine. We certainly have patients that come from far away, and you know, we've really been minimizing the number of visits, and you know, it's just what David and Gennady were speaking about. So we've already adjusted to that. So I really think these changes are going to come to the forefront when we get to protocols going forward. And really, I think it gives patients who are not within the same vicinity. So if I have a trial here and someone's in Seattle or somewhere else, they don't necessarily have to have the financial burden of requiring to come all the way down here, but yet still have the opportunity to get onto a novel treatment. So I really think your participation is going to improve over the next few years, hopefully.
Oh, that would be a very welcomed consequence of COVID-19. David, you talked about genomics being a part of really kind of your practice and your interest. And we had a lot of questions, especially from patients who are, patients are so much more informed now than ever before. I always use this comparison. I have a mom, my mom is 73 years old, and I'm 43. And the difference between my mom going into a visit and me going into a visit is night and day. I mean, I feel like I might as well be wearing a white coat that says, Sarah Loudon, WebMD, with me. And my mom is, whatever the doctor says, I won't interrupt. I won't have any questions, So patients are so informed. And by the way, it's not age dependent. That's just how it falls in my family, because I've been in clinic rooms where, there's 80-year-olds that come in with the white coat, so-and-so WebMD. Patients are asking the questions of, we ventured into NGS testing and comprehensive genomic profiling, a decade plus ago. How are you using, or are you using, especially given the importance of immunotherapies and some of the targeted therapies for kidney cancer, both in early and advanced stages, how important is it to profile patients using these assays before you create their roadmap of care?
Yeah, it's a great question, and I think like a lot of things, it's often personalized. It's something that's going to be dependent on the individual patient, and obviously it's the type of cancer as well. And I see kidney cancer, and we'll talk maybe about genomics specifically in that setting. I think as well, to sort of think in the back of my mind, there's sort of two purposes. One is what's going to be helpful in potentially charting out a course for the patient in front of you, and then what's going to be helpful in terms of learning, so that it's not just the patient in front of you, but the patient 5 years from now or 10 years from now can sort of benefit from the collective wisdom of knowing a lot more about the genomics of kidney cancer and how that might impact response or resistance. So I think in terms of what's immediately in front of us, the honest truth is, and this is someone I will say I'm guilty of not being a phenomenal steward of healthcare dollars, but I typically believe more information is better, and I like to have more information. And so for patients with advanced tumors, I often get some form of somatic mutation profiling, of next generation sequencing, to kind of understand their tumor biology. And knowing kidney cancer biology, that it's not perfect, but there's some hints as to certain genomic features that might portend something that's a little bit more aggressive versus a little bit more indolent, something that maybe has a slightly higher likelihood of responding to therapy versus slightly lower. I think the disappointing part is we're not in a place in kidney cancer where we can say we have this mutation or this series of mutation, and we can now choose path X for you, and we know that's the right thing. I think the classic example of that is in lung cancer, where you can identify a specific mutation and match a therapy to that mutation. We're definitely not there in kidney cancer. And we're unfortunately not there where we can even say this is a biomarker, meaning you have this mutation and you're going to respond or not respond to therapy. But I think for me, when I'm in practice, it gives me just little hints along the way that I sort of factor in when I'm talking to the patient and sort of sketching out an overall roadmap.
Mm-hmm.
The other thing I think for an individual patient is there are sometimes novel clinical trials that really apply to specific situations. And so that's not standard of care, but when thinking, again, the long road, things that might be options down the line. And then just to give a specific example, a lot of kidney cancers have a mutation in something called SETD2. And so there's a trial that's being run across tumor types that's specifically for tumors that that basically have a lack or a mutation of SETD2. And so that's all of a sudden now a new clinical trial option that presents itself that we would never know about if we didn't have next generation sequencing. I think for my patients, I'm always upfront and honest, saying that I think the reality is that the chance that this testing will really shape your course in any meaningful way is small. It's not zero, but it's small. But really, it adds the benefit of potentially learning about disease in general to help us know more in general. And I think many, many patients are really on board to make that contribution.
Yeah, it's funny that you kind of pointed out in that way, because as we learn more from the advocacy organizations, just the power of the collaboration among patient groups, you find that this really is, if not a shared disease in terms of people knowing each other, it's like shared as an experience. You know, I want someone else to have a better experience than I did. And so I'm willing to do, you know, X, Y, or Z in order to get there. So I think that's,
it's an incredible community, and I definitely see that sort of day in and day out.
yes, absolutely. Gennady, you know, it's very difficult now thinking about re-entering normal life. I'm sure that you have patients that are faced with anxious thoughts, you know, even though governors of all various states are saying, okay, we're moving into phases of opening. What does it mean for the cancer patient, the patient who's immunocompromised? You know, how are you counseling your patients to make decisions to look to the future of being able to go out again outside of the safety of their homes?
Well, I must admit that as a urologic surgeon, I often get some patients that are not immunocompromised yet, as they have not yet necessarily underwent treatment with systemic agents or immunotherapy. And not every treatment makes them immunocompromised. It's also true, a general statement, that cancer patients by definition may be immunocompromised and are more likely to pick up any of the diseases. Although there is some argument that some types of cancer or some sort of treatment for cancers, and just an example is like a ADT or hormonal therapy for prostate cancer have been found to have an association that those patients are less likely to have a COVID or experience lethal complications of COVID. Nevertheless, addressing your questions of indeed dealing with these patients that are likely to be immunocompromised have been extremely challenging. And some of the surgeries do make them, or I should say every surgery does make patient immunocompromised. Usually any surgery is associated with a surgeon stress hormones. Usually we have an enormous steroid surge. It is very well known that patients after undergoing surgery are in immunocompromised phase. Additionally, some of the major surgeries are associated or may require blood transfusions. Blood transfusion by definition make some of the patients immunocompromised. So there is no question that while we pick quote unquote cherries and may not be dealing with leukopenias or toxicities associated with systemic therapies, we often are still dealing with these immunocompromised patients. And in some cases, it's been most challenging to indeed find the very next right step, as just the magnitude of the surgery often is determining, once again, the risks that we're willing to take. One of the first patients that I required to operate during the quote-unquote COVID time was a patient with already after immunotherapy, already after systemic therapy, with few isolated metastases, where the surgery was found to be the only reasonable, I should say, leftover option, just because even on sequencing, we were not able to find any targets to which patient would respond. And that patient underwent a major surgery with a resection of her liver, with the removal of her spleen, and with the resection of a portion of diaphragm. Indeed, a very complex surgery. She had required blood transfusion and invariably was immunocompromised upon discharge. Her care was most challenging in a post-operative period, because this is the time when we started peaking or when our curves was going up. And every time it really required a significant thought process of what would be the best setting to see her, what time would be the best time to see her, how she would be best brought into a building or into an office. This is despite all the regular precautions that I am sure all of us have taken in every institution, with temperature screen, with masking, with gowns, with PPEs or personal protective equipment. I truly have remained worried for a long time, and this is just an example of one that was undergoing a removal of a drain. What does it mean? How many times can one be seen? You don't want to bring somebody in the office too often. At the same time, you certainly don't want to leave one at home healing by herself without a medical supervision, and try to assess a wound, a big wound, that pretty much transverses the entire body over the telemedicine. Needless to say, you can't even see the wound well, but also privacy. So there are so many things that have come into equation in management of surgical patients. One of my patients drove from Missouri for surgery. She's a patient with hereditary syndrome that Joyce Graf talked about. She has VHL. We are just like a few of us, I believe, on this phone call are a few representatives of this specialized kidney cancer centers that deal with kind of more rare syndromes. She drove from Missouri to upstate New York. She was ready to go for surgery. And on the morning of surgery, we have been given a command to absolutely cancel all the non-essential surgeries, as we were mandated by governor, of course, that we could be in violation. And despite it's a cancer surgery, I had to come and tell the patient, okay, how do we want to move? What should we do right now? I can justify doing the surgery. However, if you end up in intensive care unit, she has at least 20 tumors I must remove. So I say, if you are to undergo this surgery and require blood transfusion, may end up on a ventilator for the next day or two, which is not that crazy for these types of surgeries. I say, I just don't know who is going to be on the vent next to you. And all these things have further challenged my ability and her ability to make this kind of an informed decision. The decision was that she indeed has decided, or we both have decided, that maybe giving it a 2-month period of waiting was still safer than subjecting her to be in a hospital environment at this time. So these challenges are ongoing, regardless of discipline, whether you treat patients medically or surgically, whether you give them poisons or drugs or just surgical poisons. Unfortunately, we all have been in the same boat, and I think we all hear each other so much better than ever before, both patients and doctors, as we all have end up dealing with the same crisis.
No, I thank you. I thank you for that and for sharing, that particular patient story, because I think that, all of you doctors on the call can identify that you've had to make these decisions. And I do think that there's probably an increase in the level of shared decision-making that goes on in the clinic. Because really, you're not just talking about risk benefit in terms of what you know about cancer therapies, surgeries, et cetera, but now it's risk benefit as to, how comfortable the patient would be to take the risk that they may be infected with this virus as a result of some of your recommendations. So I know that it's just, I can't imagine, I'm so grateful for the way that all of you have kind of doubled down in your commitment to reading up, to researching, to making sure that you stay not just ahead of the information from an oncology perspective, but also, becoming overnight, immunologists, microbiologists, et cetera, so that you can make decisions and advise patients to make shared decisions. Well, this segment is over. We're going to be moving into talking with Dr. Andrew Koop from Pfizer, but I want to say thank you to all three of you. There's quite a number of questions in the Q&A I'd like you to address if you can during this particular break. And then, like I said, at the end is always when everything livens up with Q&A from the whole group. So thank you again for your time with us and for sharing your experiences. I really look forward to rounding this out with some Q&A. So I'll ask my team to change the sessions, and we'll get into some time with Dr. Andrew Koop from Pfizer. Hello, Andrew. How are you?
Very well, Sarah. How are you?
I'm very good. I'd like you to introduce yourself, what you do at Pfizer, and then I can frame a little bit about what we're going to be talking about for the next 10 minutes.
Great, thanks. And again, thanks again for the opportunity to be with you all today and for such a great program. My role at Pfizer is I lead the North American Medical Affairs group for oncology, and that means day to day I'm really accountable for leading the medical affairs team, the organization at Pfizer.
Wonderful. You know, we've done a few programs with Pfizer, and we've gotten to hear, you know, what Pfizer as an organization is doing at this time of COVID, and it stretches well beyond oncology, which, you know, when you're so tunnel visioned in either medical education or, you know, in practice, you kind of think about organizations as very one-dimensional. You know, can you talk with me a little bit about what Pfizer is doing to combat COVID-19 and what you'd like our listening audience to know?
Yeah, thanks. Again, you know, obviously we've got a large focus in oncology. We're also a global organization. So I think one of the things that's very clear to us is how do we tap into our resources, our people, our expertise to also to really be thinking about what we can do at Pfizer to help through COVID-19. So one of the things that was done very early on was this idea about putting together a 5-point plan, specifically about what can we do about COVID-19. The first thing, and I think you've heard some great examples today, is about just sharing tools and information, what we know about our molecules and the science, and publishing and putting it onto an open platform so people can access that information. Again, at Pfizer, we have a lot of expertise also outside of oncology. We've got virologists, epidemiologists, people working in vaccine development. So again, mobilizing those people together to really work and address solely on this global pandemic and working on that. We, as a global pharmaceutical company, have a lot of infrastructure around drug development, a lot of expertise there. So there's two things. The first thing is how do we share that expertise with other maybe smaller companies who are looking to develop? So how do we partner and work with them through that drug development process? But in addition to that, what do we do regarding our manufacturing capabilities? Clearly, we want to continue to develop and deliver those life-saving medicines. But in addition to that, where we have capacity, how do we continue to partner with other organizations or free up some of that manufacturing capacity? And then lastly, and again, we haven't really touched on it today, but how do we collectively as a community be ready to be engaged? Meaning, how do we engage with the government? How do we engage with the NIH, National Institutes of Health, or the CDC, or other pharmaceuticals, that we can be ready to move quickly again, that we can learn from this, and that we can be collectively thinking about how do we learn, how do we be efficient to respond to things in the future?
Mm-hmm. You know, it's really amazing. I say this to you in the few times that we've been together. It's amazing to see how quickly such a large organization has, you know, also I've used the word adapted so many times tonight, has adapted to these changing times. You know, you typically think of large pharmaceutical companies as very, you know, bogged down in regulatory and in kind of research, and you think of this as almost like an immovable machine. But really, it's so nimble because, you know, you have to be able to make quick changes, whether it be in, you know, standard drug discovery, or at times like this where you're almost called upon. You mentioned that, you know, there were other organizations that you were partnering with. You know, I heard from the chief medical officer at Pfizer that you were even working on vaccine development for COVID-19 with smaller partners globally. Can you talk to that a little bit?
Yeah. So one of the global collaborations we have is with a German biotech company called BioNTech. And again, when you're thinking about what we're doing here, it's about trying to develop a vaccine against the coronavirus, so against what we call messenger RNA. So again, the opportunity really was to work with them very quickly. And within about in the last 2 weeks, we announced actually we've got patients now being dosed in those trials in the United States. The week before that, we had patients being dosed in Germany. And again, working at risk to think about how do we start building that capability, that manufacturing capability moving quickly. Because as you said, Sarah, I think a lot of what we're doing is how to be agile. Part of that is listening, recognizing. You heard obviously from everyone on the call about how everything's changed and how you have to think differently and really do things differently. The other thing I'll share with you again, and we heard from patient advocates, we heard from the physicians today, is the importance of clinical trials. I mean, critically important, again, as you think about how do you advance the science for the next generation of treatments that everyone is in search of to really help address that unmet medical need. We obviously at Pfizer, we took a pause at some point back in late March, obviously as COVID-19, listening and obviously recognizing that the safety of patients and listening to those clinical trial centers. But then at the end of April, obviously listening for those, we've now opened up a clinical trials program again. So that is for those trials that were on hold and also the new trials. We've opened those up now, but again, at those centers with the capability who can do and can get the research up and running, where we can monitor the patient's safety effectively, but also obviously working with health authorities. So it's really approach that you're having to work with each of the sites. Again, it really does take a village of people together, collaborating globally if we're going to be, be successful in this battle that we're all facing.
Mm-hmm, absolutely. And Dr. Koop, the last question that I'll have for you, and you can spend some time on it because I think it's an important one. If you had one message for the cancer community as a whole, and maybe it's like a multi-part one message, because you're really talking to wide varieties of audience. What is that? What's that message that Pfizer wants to kind of overall deliver?
So I think, what you've heard today is a lot of people seeking information. There's multiple places that people can get information. Again, listening being part of that team conversation. I certainly share, I think, obviously at Pfizer, we've got the organization obviously mobilized around this. This is a global health situation that we're all part of, and we all need to be collaborating together. I think what you've seen is how does everyone come together? How do people think differently, work together, collaborate, and find different ways of doing things with that continued sense of urgency. So I do think that way of working and just listening and building together and working is going to be absolutely critical. The other thing I will share is just the resilience. The resilience, again, you hear it from the conversations that we have every day with advocates and the healthcare workers. Everyone is just this remarkable resilience because obviously in these very uncertain times with COVID-19, cancer hasn't gone away. Cancer is still there. It is still impacting patients, impacting families. Care needs to be delivered. And I think that the resilience that people are displaying is remarkable.
And that goes for you. I know you're sharing that with the cancer community as a whole, but that goes for you too, you at Pfizer and you in industry. The resilience, thinking about what day-to-day operations look like, let's say 1st of March to what they looked like by the end of March was radically different. And, you as large and small organizations, both in drugs and diagnostics, have approached it with really incredible resilience, still finding ways to reach your customers, still finding ways to serve your patients. This whole shared experience, this globally shared experience has brought out really the best in so much of who we are as individuals and the power of what we can do when we come together. So, I'm so grateful to hear what the organization is doing and to, evolve with you weeks over weeks as you continue to innovate and to offer things that are important to people. Andrew, thank you so much for being here. As you know, don't go away. Feel free to join into the Q&A and answer questions. We've had some questions pop up for you particularly, so please do that. I'm going to ask my team to introduce Ms. Salima to the panel. This is our patient for the evening. I also want to say, these town halls, when we decided to kind of launch them, we didn't know how we were going to do it. We are a live medical education company. I mean, our bread and butter is in events where we pull, you know, hundreds of doctors into a room and put dozens of doctors on a panel and have them speak to each other about the latest in advances in data and diagnostics. And when we decided to do this, you know, we reached out to some core partners that had worked with us in the past to develop educational programs, Pfizer being one of them, also Bristol Myers Squibb being another. And, you know, really sight unseen, they agreed to support this and not to get product information out, really to just be able to enable a platform where all of us could come together and talk. So I have to, again, say thank you to Pfizer and thank you to BMS for investing in us, for investing in the kidney cancer community, and for continuing to be both innovative and resilient. Having said that, welcome, Salima, to our town hall. I'm so grateful that you're here with us. This really is the part for me where things kind of come alive, because I love that something personal starts to happen. You know, we hear from like organizations that represent patients, and then we hear from doctors that have this, you know, experience in clinic, and then from industry that supports, you know, all of the advances. And then we really get to hear the grit of what is it like being a patient, living in this insane time, and now having to balance both all of the risks and worries and all those other things of COVID-19, along with what you were already tasked with. So start by telling us a little bit about yourself, your diagnosis, and maybe your journey to this time.
Thank you so much for having me. My journey with kidney cancer started in the summer of 2018. I was healthy, well, still healthy, but I was healthy. And just one evening, it was a Saturday night, I felt what I thought was a UTI coming on. And it was late, it probably was midnight. I was up a lot. And I told my husband, I said, you know what, I think I'm gonna go to the urgent care and just get this taken care of. It doesn't feel quite well. Nothing was open that late, so I ended up at a larger hospital here, Scripps La Jolla. I'm in San Diego, by the way. Mm-hmm. And I went to the ER, which is not usual for UTI, but anyway, I went there and I had a very just detailed doctor there. The physician in the ER said, you know what, let me just do a quick ultrasound of your kidneys. And which is interesting because, so I was 46 at the time, every year getting a physical, every year getting my mammogram, every year getting my gynae checkup and ultrasounds that go with that, but truly never really had imaging done of that area, I think, in my whole adult life. And he says to me, you know what, I think we need to do a CAT scan. And I thought, okay. I still kind of didn't think cancer. Sure. And yeah, and so I'm in the ER for a few hours and he comes back and he says, Mrs. Witt, you have an 8.8 centimeter tumor in your upper pole of your left kidney. And initially, I thought, you know, I'm not a doctor. I don't know what this terminology. I thought, do you mean like a cyst? Oh yeah, you know, like these things, you know? And he said, no, it's not liquid. This is a solid mass. You need to get this taken care of. I felt like I had been punched in the stomach. It was such a blow to hear something like that. And I came home and I shared it with my husband. Both of us kind of just the amount of anxiety, of denial, of uncertainty. And at that point, I had absolutely zero knowledge in kidney cancer, kidney function, kidney anything. Interestingly, no kidney cancer in my family. I'm 46. I thought in good shape. You know, I didn't feel any symptoms whatsoever. No blood in the urine, no pain. So it was such a shock. Mm-hmm. Right away that summer, right after that, that was on a Saturday. On a Monday, I contacted all the large university hospitals here in San Diego, and I got in right away to UC San Diego and the UC systems. And I got in within a week, and they redid another CAT scan. And they said, well, good news and bad news. You have a very large tumor. We're going to have to take out the whole kidney. And the good news is it doesn't look that it's metastasized. And I thought, okay. So from the time I found out in the ER to the time of my surgery, 12 days had passed. And I went in, and my surgery was quite late at night because I was put in as a secondary type of surgery, like on a rotation. And I had my kidney taken out. Basically, you know, it was all so fast. All I could do was read. All I could do was try to find information, and real information, you know, the Kidney Cancer Association, things that were of merit, that were of substance, that I knew that I could rely on. And I went back in a week after my surgery to get the diagnosis, you know, the microbiology of my tumor. And it turned out, sure enough, it was cancerous. It was PT3A, chromophobe renal cell carcinoma. And my doctor at the time, I said, well, what can I do? What, you know, I had all these questions, like you were talking about going in with your mom. I had this list, check, you know. And I went through them all, and he says, you know, listen, come back in 3 months. We got to do imaging every 3 months, and hope it doesn't come back. Well, it's been now, I've had 7 CAT scans. I've gone every 3 months, and after a year, they graduated me to every 6 months, which brought me right to the COVID, March 17th. Yes. That was my last CAT scan, and they've all been clear. So that's been my journey, you know, but for a little while there, I have 2 teenage daughters, having to tell them we didn't know the certainty of what was going to happen to mom, and dad not knowing, you know, we've been married 23 years, not knowing what was going to happen. It's extremely daunting time.
Yes. You know, first of all, thank you for sharing your story. I always think that, you know, there's someone listening somewhere that has had the same feelings, the same anxieties, et cetera, and, you know, finds it difficult to even communicate that because it takes them back to that vulnerable, scary time. So I thank you so much for your bravery in sharing your story. You know, I feel like there are so many people right now that are in that same headspace of anxiety, you know, what's going to happen, especially, you know, you mentioned that your scans kind of follow the 6-month pattern, and then here it was here. And there are patients that are, you know, in active surveillance for other types of tumors and for kidney cancer itself that, you know, when all of this hit, it became like, you know, is screening for recurrence really essential? And I feel like it was responsible for the medical community to say the risk doesn't outweigh, or the benefit doesn't the risk doesn't outweigh the benefit, to let them stay home at least until, you know, we figure out the level of risk that there is kind of being out there. But at the same time, when it's you who's impacted, being told that this scan that, you know, you've waited five months and 1 week to get is now maybe going to push down the road for 3 more weeks and 3 more months, you know, it doesn't take into account kind of the individual experience of anxiety. So maybe you could kind of talk to the listening audience about how you're managing being a mom, you know, being a survivor, if you're still working, you know, all the different elements of what we're all going through right now. Maybe you can just share with the audience of how you're doing it, how you're managing it.
The best I can, right? So aren't we all? But for me, my next scan was right in the middle of the COVID. It was March 17th,
Yes.
Right? And the day before my scan, you have to do all this blood work, you know, because they give you dye and you have 1 kidney, and so they were saying that day were no more elective procedures, no more elective scans for now. At that time, this was March 17th. And here you will go in the hospital with masks and gloves. And at the time, not knowing, you know, the death rate, the this, the that, the contagiousness, the anxiety was, I think I was more anxious for that than I was for the result of it. It was a double whammy. But for now, you know, in fact, for the next scan, we have telehealth, we already have a visit set up for tele. I already have my blood draw going to a smaller facility. They've made some changes. And I think really what's real important for us cancer survivors, and I think, you know, we're all fighters. And through cancer, it's a skill, learning to stay in the now, learning to stay mindful and not getting too ahead of ourselves in anxiety of what if and what we cannot control. For me, that was the most important thing to do, was to stay in the now with this pandemic and to do everything I can. What can I do to control what's best for me? I'm going to work out. I'm going to eat right. I'm going to continue doing these things. And I think that's important for all of us out there with kidney cancer or healing from surgery or on immunotherapy, is to continue doing what's best for us in the midst of all this.
Yes, yes.
You know, weighing the risks benefit ratio for me, yeah, it's a tough one. And for me personally, I felt the need to go get it looked at. You know, I had a large tumor. I am still not at the 5-year marker. I am still under strict surveillance. So I felt that I was willing to take that risk.
Yes.
And I still feel that way now. I do, with the proper, you know, with gloves and masks and things that are asked. But
yes. No, I thank you for, you know, your story and also your transparency and figuring out, you know, what's the right balance for you. Because I think it's so easy to kind of either feel the guilt of wanting to make decisions that benefit easing your own anxiety against, you know, the public good. You know, should I be going out right now to get this? But sometimes you just have to think about yourself, put your mental health first, you know, really kind of think about how you can live your best amidst these crazy times. So I thank you so much for joining us and sharing your story. I want to ask you to stay right where you are. I'm going to ask my team to bring everybody back because as we conclude this evening town hall, we've got so many questions. I feel like there's more questions. I mean, they're coming up on my phone, on my computer, on this computer, on this computer. So this is definitely an active audience. I think it's representative of the kidney cancer community. So I'm just going to kind of start with going over a few of the answered questions that I think are important for the audience to know. So, you know, a practical question, will this presentation be available at a later date? The answer is yes. Not only do we share it on our website at totalhealthconferencing.com, but it's also available on YouTube, and we do send it out to all of the participating advocacy organizations, and they can choose either to share it on their social or house it on their resource pages. You know, Gretchen talked about reliable sources of information. How do we access this? And Brian answered, you know, these three organizations right here really have reliable, credible information. So Powerful Patients, KCA, and KidneyCan, as well as the NIH, NCI, smartpatients.com, CDC, American Cancer Society. And, you know, don't discount calling your doctor's office. The doctors want to hear from you. You know, maybe they themselves can't take the call because they're going through, you know, a day full of clinical practice, but their nurses can help. You know, at some of the larger academic centers, they've got resources, shared resources where you can speak to someone. So, you know, don't discount getting in touch with your doctor's office when you have especially specific questions about your own disease. Okay, so listening to the leaders of kidney cancer organizations makes me wonder how a person can help with volunteering, even in a small way. So Brian, I mean, I don't know if your skin was tingling, but I'm going straight to you because, I mean, I feel like you're the best advocate for calling in the troops. If someone wants to volunteer, how do they do that?
Well, thanks for that question. The quick answer, I'll harken back to Tip O'Neill, who was the Speaker of the House from Massachusetts, and he said all politics is local. And every one of you that's listening in here has a voice, like I said before, and you could join us on district days this fall. We're also going to be going back to DC again when they let us. And you can reach out to any of these organizations. I'm sure they have contact capabilities. We'd love to hear from you. We'd be happy to give you some ideas about how you could pitch in and join the fight.
Thank you. Thank you. This was a question for Dr. Bratslavsky. If a patient is waiting for kidney cancer surgery, how long is it safe to wait?
It's a good question. I typed the answer. I think that it's fair to distribute this answer. So very briefly, we do know that small renal masses have a relatively slow growth. And the growth rate is on average about 3 millimeters a year. What 3 millimeters is about 1/8 of an inch. So one can try to extrapolate how long the tumor may have been there, but not always the case. Some tumors may grow slower, some tumors may grow much faster. Because the tumors tend to grow so slowly and if they're small tumors don't tend to metastasize until they reach about 3 centimeters or so, at least in vast majority of patients. But we typically say up to 4 centimeters, it is absolutely not harmful, or I should say not harmful in vast majority of cases. If there is a delay by, 3 or even 6 months, and many patients prefer to just go on something that we know is active surveillance. So those patients are typically observed or monitored repeat scans in about 3 to 6 months. Those that become a bit larger and those patients that have tumors close to, let's say, 7 centimeters, and the reason I use these numbers because these are part of the normal staging system, 4 centimeters, 7 centimeters. These are all what are known as stage 1 renal tumors. And the overall rate of metastatic spread is still less than 5%. And for this reason, if there is indeed, and again, this is after a period of observation for several, 2 to 3 years in some of the studies. So for this reason, it is not that uncommon if somebody were to come to a doctor and had an important trip to have planned or a graduation to go to or a vacation, then that is perfectly fine. We can tell patients, well, listen, if you need to give it another few months, it is okay. And I often discuss the specific percentages of or risks of those that may develop metastatic disease. Those that typically need to have treatment are the ones that presented symptomatic disease, if they are bleeding, if they have pain, and if they have something that they feel is not right, and that's how some of them are diagnosed. Those that are diagnosed in a symptomatic way, or those that have involvement of major vessels, like renal vein or inferior vena cava, those tend to, the largest vessel, vein in the body, those tend to need to have surgery. But if you look at majority of patients, in most cases, their surgeries could be safely postponed. So I think what is also important is that patients understand that not every tumor, not every kidney tumor is malignant. Not every kidney tumor needs to be addressed overnight. And while it does generate a lot of anxiety, one of the questions I also answered is, what can we do as patients to help you, doctors? And I often say, please be calm, because what we do is we risk stratify. We do our best. We do our best to minimize your risks. We are very responsible for your well-being, but sometimes given a 3-month delay in therapy is much safer and is actually quite safe, because most of these tumors have already been present for years by the time we find them. And to push it and have something done at the time of COVID sometimes probably would be more dangerous for your well-being.
No, I think that that's great to know, and I think that does ease a lot of patients' anxiety. Dr. Bupathi, I think this is a great question. For many patients, their tumors are incidentally found. I mean, I think about Salima's story, and I have a follow-up question for her after this one. Many tumors are incidentally found. Has there been discussion about screening, ultrasound, CTs, or MRIs, screening individuals at a certain age to help identify these tumors before they metastasize, kind of like colonoscopy at 50 or mammograms in your 40s?
Yeah, that is a great question. As of right now, we don't have any screening guidelines for kidney cancer. There's no data to support it as of yet. I think we just need a lot more information from a kidney cancer standpoint. We see a lot of heterogeneity in kidney cancer. There's certainly genetic risk factors for it. If there's certain syndromes, you can make the argument for doing some certain scans or imaging, but as a general rule for the overall population to undergo screening, we don't know that that's going to be beneficial. You may end up finding more incidentals, incidental masses than actual cancer itself, ultimately leading to more biopsies or procedures that may not actually be indicated. So right now we don't have any protocol in place to say that we would start screening for kidney cancer starting at a certain time frame. Now, ideally, that would be something that we can that would be looked at and would be very beneficial. You look at lung cancer. If you have certain risk factors of smoking for a long period of time, low dose CT scans are indicated to find small masses and to follow them over a period of time. We unfortunately just don't have that in our renal cell right now.
Mm-hmm. And my follow-up question to Salima, you know, this comes from the audience. What made you go to the hospital instead of going home? And, you know, I was thinking of that too. And I was thinking back to Joyce and the Powerful Patient initiative. And just thinking to myself that, you know, we are our greatest advocate and we know our bodies the best. And you followed a cue from your body saying something's not quite right. But what did make you go to the hospital when those urgent care places were closed rather than saying, you know what, maybe if I sleep on it or give it a week,
Be quite
it'll
candid.
go away?
Well, to be candid, I felt a UTI. I felt uncomfortable. I couldn't sleep. I felt pressure in the bladder area and I just couldn't sleep. So I felt that I probably needed antibiotics or something. I needed this to be looked at. I wasn't a frequent sufferer of UTIs, maybe only 4 or 5 in my whole life. But I knew something was wrong. And you're absolutely right. I think we have to pay more attention to that inner voice. I think I was, and I didn't even realize I was. And it saved me. So I'm very thankful for it.
Yeah, no, I think that that's something that really, you know, as individuals and as patients, you know, all of us in our life are a patient at some point, you know, from the time that we're born all the way through to the time that we leave, we are a patient at some point. And I think just the idea that we could become this empowered patient, or, you know, as Joyce has, the powerful patient, and tap into the available resources that advocacy organizations all around the world provide, you know, it's probably one of the most important things that we can do for ourselves. So I have one more question, and this is, I feel like it's been asked a lot of different ways, and I'm going to ask Dr. Braun to answer this just because I think that this kind of fits his wheelhouse best. If I'm a patient, newly diagnosed or in treatment, and nobody's talked to me about clinical trials, what do I do? How do I find information about clinical trials about my disease?
Yeah, that's a fantastic question. I think it's often difficult. I think there's a couple of probably routes I would take, and it's not one or the other. It's sort of doing all of these things in parallel. One is, you know, I think Joyce mentioned this, which is great, is to be your own advocate. I think if the doctor isn't bringing it up, you should bring it up too. That really is to say, you know, I'm appreciative of the standard of care options. What clinical trials might be a fit that might be helpful, and what are the limitations of those clinical trials? And I think that's always a really good place to start. The second is, I think, a tough path, but for some people it's an okay one, which is starting to do a little bit of your own research as well. That's possible. There's publicly available sites like clinicaltrials.gov where you can search for available clinical trials by disease. They're all listed. I think it's to be completely transparent, it's challenging. There's a lot of technical jargon in there, and they're not always the easiest to parse through, but for some people that's an option. And I think the third one, which I would really sort of encourage, is some of the advocacy organizations you've heard about today. There are tremendous, tremendous resources. both in terms of information they have posted, but also in terms of information that's available on forums like Smart Patients, where people can learn from each other. And I think that, especially if you don't have access to sort of a place that's running a lot of clinical trials that maybe is knowledgeable about that, reaching out to those advocacy organizations and to those other patients is a great route.
Mm-hmm. No, thank you. Thank you so much for that. And I think that that's really kind of a general, to all tumors, when you're not asked, especially when you come in with, the idea, what is a clinical trial? Will I be given, placebo versus a drug, or, something that's maybe inferior, to almost reset patients to know that you're never going to be given something inferior. You'll always have the standard of care versus something either equal to or better, or something investigative. And there are ways to find, although maybe not simple, which is probably part of the problem in adult clinical trials, but definitely going back to what Gretchen said about finding reliable and credible resources to find information. Advocacy organizations definitely are designed to help you navigate even into the clinical trial space. So, time always runs out for me with these. I always feel like I wish I had another hour to just kind of go over with everybody. But, I did a mental health. I want to just start by saying I always do something silly at the end of these to kind of humanize everybody. But in light of the fact that this is Mental Health Awareness Month, number one, and number two, I just did an interview with a psychologist from the University of Miami last night on, maintaining mental health in the time of COVID. And we went through everything from, how do you develop schedules to kind of keep you from going into overdrive? One thing that she talked about was not necessarily looking at your situation and comparing it to others, and then not letting yourself either grieve the situation or experience the feelings that you're having. It was just really such a great hour that we spent with each other. And so in light of that, this is a little bit light, but it's also a little bit serious. In light of that, I just want to go around the panel and ask each one of you, what are you? So Joyce, listen, what are you doing for you at this time to maintain positive and healthy mental health? And I want to say too, from learning from her last night, it could be maintaining positive mental health, could be allowing yourself to have a good cry. It doesn't mean you have to be positive and joyful. It just means that you have to honor the feelings that you're having. So we'll go around the room. Salima, I'm going to start with you. What are you doing to encourage your own mental health during this time?
Oh my goodness, so many things. But one, I have 4 French bulldogs, and I love just hanging out with them, playing with them. They're silly. They lighten up the mood if things are too heavy. So I have to say, playing with my critters here at home. I
love that. I love that. I love that. That's so funny because it does lead to connection. We want connection. So even with those pups that are wholly devoted to you, you're getting that connection. Manoj, what about you? Mental health in the Bupathi head.
There's a lot of things, I think, I really, what keeps me sane and to the ground is really my wife and kids. I have 2 little boys, 4 and 1. They get so excited just doing all sorts of stuff. It really alleviates anything. It kind of makes you enjoy the small things in life again, almost being like a kid at heart. So I think that's really been a lot in order to kind of get through this.
Yes, thank you. Okay, Miss Joyce.
Okay, so doing some exercises. There are lots of yoga videos, things like that. And meditation. There's also a lot of opportunities for meditation. And I find it therapeutic to reach out to other people. So I make calls to elderly friends, and I've been making masks. I think I'm up to almost 500 masks now for people in my community. So staying busy is what works for me.
Oh, you're such a love. Thank you. Thank you for that. David, what about you? How do you take care of David Braun?
Yeah, that's a great question. So I think a couple routes. One is the idea of being physically distanced but socially connected. And so, through Zoom calls, I'm connecting with people, family members or friends I haven't really spoken to in 10 years, people that are in other parts of the country or other countries altogether. And that's been really nice. And I think the second part is my own set of critters. I have two daughters, a 4.5-year-old and a 1.5-year-old. They both lighten the mood incredibly, but also have, I don't know, there's inspiring how adaptable they are. This is a totally different situation, and they go with the flow, and that's their new life, and they're able to adapt. And that's, yeah, get a lot of strength and wisdom from that.
Yes, and I know, talk about socially connected. I hear that there is a hilarious picture of your home office setup. So I encourage everybody to search that on Twitter. In fact, I think we'll make sure that we repost it on all of our social media channels so everyone can take a look and have a laugh. Dr. Koop, how about you?
So as you know, Sarah, I've got 3 young children who keep me somewhat busy, and I have to say, keep me grounded. I mean, I've actually used the opportunity in the last couple of weeks to do things that in some ways almost other people do. They've learned to ride the bikes, and I've had that opportunity. They've learned to draw. I like to draw, so I can actually do that. So in some ways, the positive is that I'm actually getting a chance to do things that might have been done at school or other people might have done. So just having that time to teach.
Yes, I love that. Brian?
Yeah, I've got a yin and yang side to me. So I do quite a bit of work, but also a lot of long walks with our Philadelphia chocolate lab named Benjamin Franklin. And I got to give a shout out. My mother has turned 102. So we have great genes in this family. So I call her because she's seen a lot.
Oh, amazing. I bet she's seen a lot. Wow, just to sit with her would be a lesson in history. Amazing. Happy birthday, Mom. Gretchen, how about you?
I find, being the introvert in this group, I find, solitude is where I kind of regroup. So even though this has been very hard, I always look for the meaning in something. And I think that's what people are missing. They're maybe looking for the meaning in all of this. And we're finding that we're coming back to basics, finding things that are meaningful to us, things we should have been focused on to begin with, so we can stay connected, and as well as something we can control. I think that's part of what's missing. I think it's also missing from our cancer patients' lives as well. We're just looking for something that we can still control because everything feels a little bit out of our reach. But between a routine and working out and really a little pup that I've been trying to keep quiet like this whole entire time. All of those things, and friends, whether it's virtually or not, those are all things. We did a segment actually that was said, what keeps you safe, sane, and joy, and brings you joy. And so those have been really interesting. There's also a common theme, I think, through everybody, and that's kind of the messaging I'm taking away from this entire pandemic.
Yes, I love that. Coming back to basics, I love that. Dr. Bratslavsky?
Okay, I'll be brief. First, I ate a lot, but then I had the Zoom schedule, so I needed to fit on the screen, so I ran with my kids for the past 2 weeks. I taught them my 3 uncontrollable boys of this year, 17, 15, and 11. I taught them a very sophisticated card game that I played back in Ukraine, and I was surprised how they got it. So now in the morning they wake me up because they scream and argue over that game and rules. So far it's been therapeutic too. And as soon as we're over, I'm actually going to go on. It's a little after 8, but still light outside. They already texted me because they want to play soccer with me. So I've been MIA as a father for the past 20 years or so, whatever, 17, trying to work. And I actually will go and play soccer with them, something that was, unthinkable during the work week before.
Yes. I think that really, thank you for everybody sharing that. I think that really is, we've learned to live with so much less of everything, less of consuming, Although the first week, I think we were all consuming way more food than we ever thought we could. But, you know, less consuming. Think about, you used to go to the mall, go to Target. I would go to Target to spend, you know, $20 on one thing and come out with a $300 cart of stuff I didn't even need. And, you know, less work, less thinking that if we're not killing ourselves working, that some fundamental thing about our life would shift, you know, just so much less. We're learning to live with less, to enjoy the more of family and friends. And I know Mother's Day just passed. For those of us who have moms, it was like the first the first Mother's Day that really meant so much, because it was like, I invited my mom to my house, and I thought to myself, what a wonderful, special surprise treat to be able to have her. And I don't know that if before this time I really valued that I did still have her. So I know that, you know, this has really brought us to a place where, as Gretchen said, you know, we figure out what keeps us sane, what keeps us safe, and where we find our joy. So I thank all of you so much for joining us for this. You know, I say this at the end of every one. These matter. You know, I've been in medical education for years, and I feel like at the end of every big CME meeting, I say, oh, good job, good job, good job. But these, I think about everybody on the listening side, and I think how much they appreciate the positive news, the credible information, and just the fact that people are giving their time for them, you know, for them. And that matters, that means something. So I thank you so much for your time. I look forward to a time where we can all see each other in person. Manoj, I can't wait to be in Denver and give you a squeeze upon squeeze, because I see him every year in Denver, and this summer I won't. So next summer, expect a triple, quadruple hug.
Looking forward to it, Sarah.
But I thank all of you. I loved meeting all of you, and I hope that we continue our relationships well beyond this town hall, and that our relationships lead to impact. So I pray for all of you, for your family, for your missions in life. And again, I look forward to a time where we can all be together. Thank you.
Thank you.
Thank you.